Welcome to Pathways to Equity, a podcast that presents ways to make health systems around the world more equitable for everyone. I'm Nathan Blanchette, your host. So far in this series, we've learned about some of the roadblocks that exist to equitable health systems. We've also shared that when trying to make a more equitable health system, it's important to measure the changes so you know what's working and adapt accordingly. In this episode, I want to share another best practice we've learned through our work with the Accelerator, engaging the local community and civil society to get feedback on and advocate for the health system they want. In this episode, I talk with three people working on improving health systems in Togo, Benin, and Guinea. In each of these West African countries we're going to hear about, the governments were rolling out ambitious new health programs and strategies. These include a new universal health coverage plan in Togo, a health insurance program in Benin, and a national community health policy in Guinea. In each place, the government and civil society organizations, or CSOs, worked together. The government learned from the people who would use these new health programs what they wanted and needed from them. We'll hear about what type of community groups and civil society organizations were involved, and how their feedback was used to ultimately design and implement more equitable, responsive health programs. I hope you'll enjoy learning about what taking concrete steps towards achieving universal health coverage on the ground looks like as much as I did. Our first example comes from Togo. In 2011, the country launched an initiative to achieve universal health coverage. Since then, different aspects of that goal have come to fruition. One of those is the creation of the National Health Insurance Institute, which supports retired people and civil servants in Togo. They've been studying how to get basic health care to vulnerable populations, and in 2021 offered free health services to pregnant and postpartum women as well as newborns. In 2021, the legislature also created a law that establishes universal health insurance. Someone who has been instrumental in all of this work is Dr. Kefilath Bello.
I've been working as a primary care physician for more than 10 years, but now I'm more working on research related to primary health care and universal health coverage.
Dr. Bello is the Deputy Director at the Center for Research in Human Reproduction and Demography, or CSOs, which was the Health System Strengthening Accelerator's partner in Togo.
We've been working in Togo for more than, almost 4 years now, with the Health System Strengthening Accelerator project.
Dr. Bello says in the 4 years she's been working with Togo to build up their universal healthcare program, engaging civil society organizations has always been a priority. I want to ask you more about this word co-creation that you used and the involvement of civil society. So I understand that you have multiple stakeholders, you're working together to create a plan. Can you tell us a little bit more about who that is?
So we first tried to have these three different categories of stakeholders. So we had a government official, both at the national and the subnational level. And we also had representative of health practitioners, both in the public and the private sectors. And also we had people representing the public health facilities. We had people representing the community-based health insurances. They had within them workers that work in the informal sector and also those who cannot, for instance, afford like big private health insurances. We also had organizations representing HIV, people living with HIV or those working with HIV, and also organizations working in sexual and reproductive health.
You mentioned some of the groups that they're representing: women, youth, people living with HIV/AIDS, perhaps people with disabilities and communities that are in more rural areas, perhaps not as typically involved in policy-making processes. As you think about some of those groups and all the co-creation meetings that you helped facilitate, what does it really mean for them to be integrated into the plan?
I think it's more a matter of having a space also to explain their voice. So first of all, I think all the parties really recognized that it was important to know better what are the needs of the population. And the second thing also that came out quite strongly was that there was a need to a better follow up and better accountability in the implementation of the roadmap. There were many policies that were developed but were not really moving forward and were not really implemented.
It's easy to pass a law. It takes a lot more to build infrastructure and actually implement what a law requires. Dr. Bello says inviting civil society organizations to these UHC meetings helped create more accountability and gave the CSOs more confidence to engage in this process.
Sometimes I think it helps them to have more legitimacy also to have these activities. But I think it's more a matter of having a space also to explain their voice.
Very interesting. I was just thinking of the word legitimacy as you were describing it, and then you said that. It really seems like that's a big part of what's going on here. It's giving formal sort of government-endorsed legitimacy to these groups who otherwise would just be on their own.
It's not a contract with the government, but at least formally to be known to say that, well, these organizations are really representing the community and they have to be invited in spaces. So I think it's really a matter of visibility, a matter of legitimacy, if I can say it so.
Dr. Bello also found that after working with the accelerator, the civil society organizations felt more comfortable advocating for local reform.
So we had two of them, one representing women and another which is more representing people working in the informal sector. So we had two of them conducting also local dialogues. So they had activities where they not only sensitize the community members, but they also have this dialogue with the local authorities, so the mayors and their administration. They did like advocacy, for having a better financing of health at local level. So I can just say that it's also, helped those people or those organizations at the local level to have the tools so that they can really try to improve what they were already doing as their work. So it is what I can also add related to how our support helped them really to make their voice heard. Another example I can also give is we also had a community dialogue with an organization representing people living with HIV. The dialogue was really around supporting better, actually, the people who face discrimination. The organization was also trying to work with the local authorities and also key community leaders so there can be a better support system around these people living with the HIV who face discrimination. So this is at local level. I won't say that it changed things, but really at least it helped raising awareness on issues where local authorities usually don't see.
You've been very directly involved with these groups and this whole process. I know that it is a lot of meetings. Sometimes things don't move very fast. There's a lot of policy discussions. Do you have hope that this is going to change things for the better? Do you have hope that the way people in Togo are going about this will really help improve health in Togo?
Yes, I think I have hope. There is also a lot of challenges, but I think the good thing I'm really happy of is that the dialogue had started and it's kept going. So it's not something maybe we can measure, with hard indicators, but really when we started the work in Togo, one widely shared frustration is that we don't have the dialogue. People are working in silos. We don't really know what is happening in people's offices. So I think at least this dialogue has started. Something that is very, very important of such processes is that there is really a need of a facilitation, of some, let's say, some people facilitating the processes. And for now, the accelerator have been playing this facilitation role. We did it together with the let's say, the UHC program. And it was really agreed upon that now that this is more formal and is on the paper, that the commission should meet every quarter. So, the ministry should really try to keep this regularly. So I think what is changed is mainly related to the follow-up and the implementation of the policies. So I can say these are the things that we can see that change a little bit, but these are also long-term processes, and it's not very easy to have a change, just now. But this is what I can see actually as some little progress that we did.
Thank you to Dr. Kevilath Bello. She is the Deputy Director at the Center for Research in Human Reproduction and Demography. Serhoud is a Benin-based organization that carries out regional technical assistance and research on health system strengthening and related issues. Another country that is trying to reach universal health coverage is Benin. One of the most significant advancements toward this goal came in 2019, when the country established a national health insurance program called AM-ARCH. For a long time, patients in Benin had to pay expensive fees to get healthcare. We talked more about these user fees in episode 1 if you missed that. This new program is trying to make healthcare more affordable, especially for Benin's low-income residents. And that's where I started my interview with Dr. Conrad Tonukwen.
I am a medical doctor, public health specialist. I am the country director of AFOD in Benin, and I've been running a health system strengthening accelerator project from Benin.
So you're working in Benin, and I know that Benin has a pretty new universal health insurance program. Can you just tell us a little bit about that program and what its goals are?
In its effort to achieve universal health coverage, Benin initiated an ambitious pilot program for extending access to health insurance for the country's most vulnerable. And this comprehensive social program, called l'assurance pour le renforcement du capital humain, insurance for strengthening human capital, or ASH, is comprised of 4 components: occupational training, microloans, retirement pension, and health insurance. Health insurance called assurance, and AMH targets approximately 1 million of the population of the country who are the poorest of the countries.
What were some of the key challenges you think Benin was facing that affect equity, as you were thinking about equity earlier, as you started this work?
The first challenge that we were facing around equity was the enrollment of the right person. This is related to the methods used for the enrollment. And the second one is how we make sure that there is an inclusive decision-making system in place. We realized that there was a gap in the inclusiveness, and there is lack of collaboration between the main actors in the country and those people who are the beneficiaries of this new health insurance program are not participating in this process. They are even not aware of the existence of this program. They are not represented.
You mentioned inclusive decision making. So what do you mean by that, and why is that important for the design of a health insurance law?
We realized that the decisions were made by people who were sat only in the office, and they decide on the behalf of the beneficiaries. And those beneficiaries, they are the poorest of the population. They are living in remote areas. How can we ensure that we take into account our social and cultural norms? Because besides the health insurance program, we were aware that we had a problem in the health system because our health system sometimes does not meet expectation, taking into account the social and cultural norms. So we realized that the beneficiaries were not attending the health facilities because of many reasons.
This was Dr. Tonoquin's challenge. The new health insurance program was meant to benefit Benin's poorest and most rural population, but those people on the whole didn't really know about it. This is when he and his colleagues also turned to civil society organizations. One way they connected to the right people was through what they called the Consultative Committee. This committee was a group of government officials, partners, and civil society organizations. People working with the accelerator serve as facilitators, and they all met up to 4 times a year to discuss ways to get to universal health coverage. The CSOs that participated were health insurance organizations, including private insurance providers, doctors and hospitals from public, private, and faith sectors, and then social workers, trade unions, and other people from local communities around Benin. During their meetings, government and health officials were able to explain the new universal health insurance program. Also, the civil society members gave the government feedback on the program.
It was a great challenge at the beginning because, the government wants the control of the information. And the government hates to be criticized for this initiative. But what we did as accelerator is to show the added value of this platform to the authorities. The idea is not only to criticize, the idea is to have a common vision on what we need to improve. The goal is to ensure that those vulnerable people, those who are living in remote regions, those who are not reachable, they get access to care. So this was creating an environment that facilitates the dialogue and improve everyone on the way that we have the same goal.
Can you say more about what the government started seeing as these meetings happened and the value that they were finding in it?
So they are not aware of the realities on the ground. But when people are sitting in the same room and local authorities, civil societies, health providers, social actors are saying the same thing, the authorities are now aware of the difficulty on the ground. And when they can see that, wow, there are some easy solutions. Sometimes the solutions are so easy, and there is just the lack of communication that made the problem so big. So they found out that they could solve many problems with this consultative committee. And also, you see, they were so happy of the results that we were getting that the authority, the National Health Insurance Authority, decided to institutionalize the carte de concertation, to appropriate this on the side, to say that this is an initiative that we will still be taking into account even after the closure of the project.
So it's been formalized. It's a set policy now, process that will happen in the future.
Yeah.
What about the other side, Conrad? Can you tell us about some of the particular groups that were involved in this, and what value did they see in it for themselves and for the groups of people that they're representing?
I think the first example I will give is the private sector. When we started, for the first meeting, we wanted to invite the private sector, and the government said, no, we don't want the private sector because our vision is to strengthen the public sector of health. If we accredit the private health facilities, we are not going to strengthen the public sector. So we started thinking about that. We strategized. We started providing evidence to show the government the importance of the private sector. In fact, there is a study conducted by USAID in Benin, and this study showed that more than 45% of the population in Benin is going to the private sector. So for the third meeting of the consultative committee, they agreed that we could convene the private sector. And this was a great success for us. And also the private sector fed value. And another progress made with this consultative committee and this dialogue is that the faith-based organizations of the private sector are now being accredited in this new health insurance program because they accept to use the same cost as the public sector.
That's great. I see so many important things there, particularly on just actually making this program work in the real world. There's certainly lots of examples of policies that get passed, which maybe are designed well, but people aren't even aware of them. You know, you're Beninois, you know Benin. Are you seeing that actually you have some better awareness by people in rural communities, for example, better participation in the program, things like that?
We conducted an evaluation that showed that although the insurance premiums of the poorest were covered by the government, these people did not use the services for several reasons. I will give 3 of them. The first one is travel costs from their home to the health facility. The second one is the fear of stigma. And the third one is lack of information. We needed to tackle these 3 factors to see some progress on the field. And we put in place, in collaboration with the civil society organization, some initiative. So there are regions very far from the health facility, and in collaboration with the health providers, we organize some mobile consultation to meet the population to show that there is services available that can benefit to them, to also motivate them for the next times to be able to come to the health facilities. For reducing the stigma, the CSOs, they organize a awareness session for healthcare providers. There were some initiative like using motorcycle riders to share UAC messages, because those motorcycle riders, they can go everywhere in the country. So this is a very useful mean to reach people who are living remotely. And also using community radios. Most of the people, they don't have TV. They have one radio and they can listen to the news. And also there is an appointment that most of the population never miss, is the market days. So we use the market days to provide information on all this. So putting all those initiatives together, we can see some changes in the region where we are experiencing those initiatives.
So Dr. Tonequin and his colleagues facilitated a lot of important conversations between these civil society organizations and the government. They came up with ways to advertise the new health insurance system to people living remotely. And they also created a complaints management system for people to give feedback on this new program. They decided that a civil society organization will receive user complaints first, because the goal is to find a local solution first. If local authorities can't address the issue, then the complaint will travel to higher levels of government. So tell me more about the user complaint system. So why is that important? Who runs that?
So when you to take an example of the health facility, there will be a member of the community identified as the contact person, and who all the people of the community already know. And to treat the complaint, there will be the local authority, the head of the village, for instance, and there will be the head of the health facility. 3 of them will treat the complaint. If there is local solution, they treat the complaint and they get the feedback to the complainer. And when there is no local solution, they can give the feedback at a higher level where the solution can be found. The issue with the complaint management in health sector is that in our communities, socially and culturally, the health provider are seen as small gods. So the population, they fear to complain of their mistake. And this is a very big issue that we we are tackling.
I was particularly struck when you said that patients had fear in some cases. Is that part of the equity story here?
Yes.
What does that say for equity? And make that connection for us a little bit between that and something that might sound like a bit of a bureaucratic process, a consultative committee.
Why do they fear? They fear because there's in their mind, they can say, if I complain, next time when I will have a bigger health issue, I will not be treated. So there is a lack of equity there because they are not aware of their rights. So there is a problem of power between the health providers and some level and some layers of the population. And this is where the civil society can play a big role for patients' rights, working on patient rights, working on accountability.
Thank you so much to Dr. Conrad Tonequen for speaking with us and sharing all that great work happening in Benin to implement its national health insurance program. You are all doing such important work to make sure that the poorest and most undeserved communities know about this program, can access it, and know their rights about using it. Thank you. To end this episode, I want to quickly share about a new pilot program the Accelerator is supporting in Guinea. Molly Loria is a senior research specialist at ICF, one of the Accelerator's consortium partners. Using social and behavior change methods, she has been working to create a tool that will help leaders in Guinea improve the transparency in local government budgets for financing of community health. The hope is that this tool could help civil society organizations in their advocacy.
So really what tool is, it's a detailed slide deck that really describes in great detail the national community health policy and also explains the context for the budget processes in Guinea and describes how to integrate behavior change approaches into budget advocacy strategies.
Molly and her colleagues recently finished this tool and a slide deck filled with information, and I wanted to know how it will be used to create a more transparent budgeting process.
We also developed an accompanying guidance designed to lead users to process and use the information that's noted in the tool to then develop and prioritize their own advocacy goals, to help them to conduct what we call behavior mapping, which is really just identifying behaviors and actors and thinking through what can be changed or amplified to support budget advocacy goals. And so using the behavioral insights that come through from behavior mapping, you then use those to design tailored advocacy approaches. And so the behaviors targeted are dependent on those implementing the tool.
One example of how Molly and her Accelerator colleagues hope the tool will be used is for local governments to budget for community health, and specifically to recruit and pay for community health workers. In 2023, Guinea passed a law that said municipal governments would pay the salaries of community health workers, or CHWs, instead of relying mostly on partners and donors. But so far, that isn't happening regularly.
In this case, in Guinea, CHWs are unpaid volunteers, and oftentimes CHWs can disproportionately be women. So this issue in itself is an equity and social justice issue, and the policy per design is pro-equity. But where we're working at right now is really ensuring that the policy, its implementation matches the pro-equity foundation of the policy itself. The really big goal right now is to transition to the government to be paying for these workers, again, at the national level and then at the subnational level per the policy.
This approach is new in Guinea. It's still being piloted, but she and her colleagues have been able to test it out with civil society organizations in Guinea to see how it might work in a larger context.
We piloted the tool with a number of CSOs in 3 different regions. In Guinea, we had them go through the tool, go through the worksheets, and themselves identify behaviors that needed to be changed and key actors that could be useful. Many of the CSOs identified pathways and strategies for advocacy, and they all entailed, we're going to go and we're going to use this particular institution. And by going to this particular, monthly meeting, this is where we're going to do our advocacy. And then it led to this really compelling dialogue between the CSOs and also between our facilitators of the pilot, which included individuals who worked for the Ministry of Health. And then it led to this larger conversation about how those institutions currently function and how at present civil society and, vis-a-vis citizens are able to participate in those institutions, and how their participation may or may not be able to lead to, increased accountability for policies or, let's say, government spending.
Molly Loria works with the accelerator supporting work in Guinea and other countries, using social accountability and behavior change insights to support citizens and civil society organizations in carrying out budget advocacy for Guinea's community health workers. This is the last episode of Pathways to Equity, and I want to thank everyone who took the time to speak with us. Hearing about your work firsthand was so important, and I thank all of you for making it happen, despite busy schedules, unstable Wi-Fi, and different time zones. The accelerator helped build new frameworks and introduced some new ideas and approaches, work that our partner countries will continue to build on into the future. Enhancing equity is not easy. It can take years to see progress and change systems. But we've learned a lot from our partners. In just these 3 episodes, we've heard about ways the field has evolved over the past 20 years, and how policies that appear to be pro-equity and pro-poor can have unintended results. This underscores the need to pay attention to equity in all phases of policies and programs, from design through implementation to assessment, and why it's important to use techniques like implementation research to measure equity in different ways and to check results. We also heard about the importance of including diverse stakeholders, especially those who are part of or represent vulnerable groups and civil society, in designing and implementing strategies to advance universal health coverage. Creating a more equitable health system comes from many people and many strategies, and all of it adds up to better, more accessible care for all. So I also thank you listening to this podcast. Understanding the nuances of this work allows more people to advocate for and enhance health equity. Pathways to Equity is a production of the Health System Strengthening Accelerator, funded by USAID. You can learn more about the Accelerator's work at our website, acceleratehss.org. That is linked in our show notes. I'm your host, Nathan Blanchett. The rest of our team is Melanie Morrow, Leor Miller, Elle Catron, Alexander McCall, and Nikem Wellington. This podcast was produced by Claire McInerney. It was mixed and mastered by Megan Palmer.